Patients with heart failure are the most common cause of readmittance into a hospital system after being discharged. So we're going to talk about the heart failure patient as it relates to cardiovascular emergencies in the pre-hospital environment. Heart failure occurs when the heart cannot pump fast enough or powerfully enough to empty its chambers. Blood will back up into the systemic circuit, the pulmonary circuit, or both. Heart failure is a syndrome, not necessarily a disease, and it's caused by any of several disorders that impair the ability of the ventricles to fill with or eject blood. It's identified based on the symptom onset, acute versus chronic. The ventricle initially involved, although failure of either ventricle can occur by itself, they often occur together. So right ventricular failure is often a result of left ventricular failure. When right ventricular failure occurs due to COPD, because the right ventricle is pumping blood to the pulmonary system, and with COPD you get pulmonary hypertension, causing the right side to often fail, that's called cor pulmonale. But then that can cause a backup where the left ventricle has to pump harder against that backed up systemic circulation, and now the left ventricle will fail. And it happens in the other direction as well. When the left ventricle fails, let's say due to chronic hypertension or acute myocardial infarction or something like that, it'll back up into the lungs, and the right ventricle will end up failing because it's pumping blood to the lungs, and that backed up blood within the lungs is causing an increase in pulmonary hypertension, just like COPD does. So there are many different causes of heart failure. The disorders of the pericardium, the myocardium, the endocardium, or even the great vessels can cause heart failure, such as coronary artery disease is the most common cause, valvular heart disease, dysrhythmias, cardiomyopathy, and long-standing high blood pressure or hypertension. So the three main factors affect stroke volume: preload, afterload, and contractility. And we know that stroke volume is super important when it comes to cardiac output, because stroke volume times your heart rate actually equals cardiac output. And cardiac output is, your amount of blood pumped in a minute. So it's a very important component to your physiology. Subsequently, heart failure can actually be caused by any condition that affects those things: preload, afterload, contractility, or heart rate. If you affect those things to a certain degree, you can cause the heart to fail. Preload, okay, if you don't have enough preload, your heart isn't going to be able to eject enough blood, and it'll start to work harder, and that is when you start to have heart failure, when your heart has to work harder and is ineffectively pumping blood. Afterload, again, we talked about how backwards heart failure can occur when the left ventricle has to pump against an increased systemic circulation. It could fail. When the right ventricle has to pump against an increased pulmonary circulation, it can fail. And then contractility, of course, for obvious reasons. When you have a heart attack and you have a loss of cardiac contractility, you could have a heart failure. And then heart rate, we know many dysrhythmias can cause cardiogenic shock by way of heart failure. So there's a guy named Frank Starling, and he came up with Starlings Law. And according to Starlings Law of the heart, an increased venous return augments preload. So breaking that down, your heart muscle fibers stretch in response to the expanded volume or preload before contracting. So those muscle fibers in your heart have to stretch to allow an increased preload. This stretching allows the heart to eject more forcefully the additional volume, thereby boosting stroke volume. So even though you are getting more volume, you're also going to get more force because of that increased volume. The more the heart stretches, just like a rubber band, the more force it's going to push out that increased volume. In the normal heart, the greater the preload, the greater the force of ventricular contraction, and the greater the stroke volume, resulting in increased cardiac output. So first we'll talk about left ventricular failure, and there's two different types of left ventricular failure. You could have systolic failure, which is when the left ventricle doesn't contract normally and has trouble pumping out all of the blood to the body. So with systolic, it has a hard time. So this is failure to pump blood out. And then with diastolic failure, the left ventricle contracts normally, but it has become stiff, impeding its ability to relax and fill with blood between each contraction of the heart. So this is failure to fill with blood. Failure to fill with blood. All right, so those are the two types of left ventricular failure, and the common causes are maybe a faulty heart valve, an acute myocardial infarction is a big one. I mean, if you're talking about that stiffness with diastolic failure of the ventricle, then that's probably caused by really bad arteriosclerosis and subsequently a heart attack. Also, cardiomyopathy can cause either one of these, systolic or diastolic failure, and excessive volume or pressure. So left ventricular failure is more common, and with left ventricular failure, your blood backs up behind the left ventricle, causing a chain reaction. So the right side of the heart will still pump normally when you have left ventricular failure, and the left side, it can't keep up with the preload that the right side is sending it from the lungs, right? And the pressure will increase, that back pressure. So pressure within the pulmonary vessels will then increase because the left ventricles can't accept that blood from the lungs, and fluid is forced out of the pulmonary capillaries into the alveoli because of that increased pulmonary pressure, and that causes pulmonary edema. And then this buildup of fluid will widen the gap between the alveoli and the capillary membrane, impairing the diffusion of oxygen and carbon dioxide. Of course, if somebody has pulmonary edema, they can then become hypoxic. And then if the right ventricle is pumping blood to those lungs that have an increased pulmonary pressure, the right ventricle will have to overcome that high pressure and congestion within the pulmonary vessels, and it will have to start trying to work harder to be able to eject its blood from its walls. And of course, when the right ventricle can't keep up with that increased workload, the right ventricle will fail, and then you'll have biventricular failure. Blood backs up behind the right ventricle, raising pressure in that right atrium. Blood backs up into the superior and inferior vena cava, and then the veins will become congested with blood, organs become congested with blood. Splenomegaly is a common side effect of right ventricular failure. That's one of the organs. Even hepatomegaly is known to happen as well, a large liver, large spleen. Rising pressure within the veins forces serous fluid through the capillary walls and into the body's tissue, producing edema, right? We know peripheral edema is most apparent in the feet and the ankles, and they might have pitting edema if it's been there for a long time. They could have sacral edema. Serous fluid may also build up in the abdomen and causing ascites. Sometimes they have to get their bellies tapped and get the ascites fluid, expelled from in there, aspirated from their belly. The pleural cavity, you could actually have a pleural effusion as well. And within the pericardial cavity, you can have a pericardial effusion. So the blood third spacing, or I should say fluid third spacing, because not all of the blood will actually shift across those membranes, but the serous fluid certainly does. As right ventricular failure then progresses, generalized edema of the entire body may occur, and this is called anasarca. As I said before, even though the most common cause of right ventricular failure is left ventricular failure, it can occur also by itself without left ventricular failure in conditions such as a right ventricular infarct, your pulmonary embolism patient, we call that acute cor pulmonale, your pulmonary hypertension from COPD, we call chronic cor pulmonale. Pulmonary hypertension is a disorder in which the pressure in the pulmonary arteries is higher than normal. So it's like regular hypertension, but of the pulmonary circulation. And the right ventricle must work harder to overcome this increased resistance to eject its blood. The right ventricle enlarges and eventually fails. So remember, hypertrophy and failure kind of go together. And when both ventricles fail, you end up with cardiomegaly, a very enlarged heart. And that used to be how they diagnosed heart failure, was by chest x-ray. They would see a big heart, and that was the only thing they would do. Now they do something called a BNP, B-type natriuretic peptide, because that's produced in high levels in patients with heart failure. And right ventricular failure caused by pulmonary disease is called cor pulmonale, so it should be easy to remember, and it's usually the result of COPD. Of course, you have compensatory mechanisms that attempt to improve cardiac output by manipulating the following: your preload, your afterload, your cardiac contractility, and your heart rate, right? Those are all the things that can cause heart failure, and now we have to try to compensate for those things. Ultimately, compensatory mechanisms may actually worsen heart failure. The sympathetic nervous system boosts the heart rate, increases the force of contraction, constricts blood vessels. We know the renin, angiotensin, aldosterone system also will cause fluid retention because it's trying to build up volume for blood pressure. It also causes really potent vasoconstriction. In addition to the sympathetic nervous system. So you're having your sympathetic nervous system and your renin, angiotensin, aldosterone system all working to increase blood pressure by retaining volume, constricting blood vessels, increasing heart rate. And what that ends up doing is causing more congestion and really bad hypertension, causing the heart to work harder and actually enlarge even more. So that accelerated heart rate and stronger force of contraction will increase the heart's oxygen demand. It'll reduce the amount of time the ventricles have to fill, and it decreases time for the coronary artery perfusion. So again, compensatory mechanisms from the sympathetic nervous system cause an increase in oxygen demand with a failed heart, which are not good things to combine. And once again, stimulation of the renin, angiotensin, aldosterone system by decreased blood flow to the kidneys, the heart has to work even harder to pump against those high pressures created. Aldosterone will encourage sodium and water retention and increase blood volume. Remember that angiotensin 2 is a very potent vasoconstrictor, so you have an increased preload from increased volume in addition to an increased vascular resistance, and now you're going to have a heart actually having to work harder to pump against those high pressures. So compensatory mechanisms increase cardiac output for time, but eventually heart failure will advance. Sodium and water retention enlarges the heart's chambers. Ventricle walls will thicken and weakening the force of the contraction. The force of contraction will continue to decrease, and then the heart is unable to handle the increased volume of fluid, and cardiac output will slowly decrease. While the compensatory mechanisms meant well, they're actually the cause of much of the congestion and congestive heart failure. So, of course, let's talk about assessment next. And your patient may report a sudden onset of dyspnea or shortness of breath, and it's shortness of breath that has worsened over a period of hours or days. It persists even when they're at rest. Okay, that's kind of an ominous finding. The likelihood of a cardiac origin is greater if the patient has a history of any of the following: heart attack, high blood pressure, valvular disease, or cardiovascular conditions. Of course, if they have a history of heart conditions, then that's a good likelihood that there's a cardiac origin involved here. The patient may report having trouble sleeping at night, and they might have episodes of that paroxysmal nocturnal dyspnea that we talked about before. The patient often reports feeling tired or weak, and they may report having had trouble concentrating. They may be it may be the result of hypoxia. Remember, hypoxia causes altered mental states, and the brain doesn't work as well under hypoxic conditions. Other symptoms include nausea, loss of appetite, feelings of faint palpitations, irregular or rapid pulses, or any dysrhythmia really. Ask the patient about prescribed medications, specifically beta blockers or calcium channel blockers, because those also will decrease your patient's heart rate and can cause cardiogenic shock. Restlessness, anxiety, or unexplained confusion might also be a result of hypoxia, those hypoxic states. The sympathetic nervous system's response to hypoxia and the body's compensatory mechanism to maintain cardiac output cause a rapid respiratory rate and heart rate. They cause pale and cool skin, diminished peripheral pulses, and an increased work of breathing. So make sure you assess for those things. And as that hypoxia worsens, the patient may become cyanotic, or they might cough frequently. And the coughing, it might produce a pink frothy sputum. We know that's indicative of congestive heart failure with pulmonary edema, right? And that buildup of fluid in the lungs will cause crackles, also known as rales, or maybe even wheezing. Remember, a wheeze could be a cardiac wheeze. So when you assess lung sounds, don't think wheezing must equal COPD or asthma or bronchoconstriction. It could be caused by a cardiac cause. If right ventricular failure accompanies left ventricular failure, then they might have like JVD, right? Because blood backing up from the right side is going to show up in those neck veins. It'll be visible when the venous system becomes congested. Patients who are able to walk will have swelling of the ankles, feet, calves, or legs. That's kind of a hallmark finding of your right ventricular failure. Patients confined to bed may just have that sacral edema. And if edema is present, note and document if it's pitting or if it's non-pitting, and if it's localized in the ankles to the mid-calf or the knees. Also, they might have an enlarged abdomen due to ascites, right? Ascites is the Greek goddess of fluid in the belly, so it's easy to remember. As the pump continues to fail, the heart rate will begin to slow, blood pressure will fall, and then cardiac output decreases substantially. Cardiogenic shock could occur, and that happens when heart failure is accompanied by hypotension. So cardiogenic pulmonary edema with hypotension is like classic cardiogenic shock. So be ready to treat those patients, and typically pressors are your go-to modality. Remember, this stuff doesn't happen in a vacuum, and your signs and symptoms of heart failure may be present with other conditions as well, right? So, and those other conditions can cause heart failure. So these patients could be experiencing multiple pathologies at the same time. So let's talk about the goals of management. You want to make sure you decrease respiratory distress and work of breathing. That's a big one. Maintain adequate oxygenation and perfusion. That's kind of the goal of a paramedic at all times. It's the goal of any emergency clinician. Direct supportive efforts towards decreasing the workload of the heart. All right, so you want to make sure the heart doesn't have to work harder, just like with an MI, because that heart failure will worsen. So we want to try to decrease the preload, decrease the afterload, maybe clear out the lungs. Chronically, these patients are treated with diuretics to decrease the volume, which will decrease preload. We treat them acutely with nitrates if their blood pressure can handle it. Nitrates are the perfect medication for the congestive heart failure patient because they're super hypertensive usually. They'll have a really increased blood pressure and they can handle it. So it'll bring down their blood pressure, but it'll bring down their preload and their afterload. And actually you'll have some clearing of that, pulmonary edema just from nitrates alone. Then you couple that with something like CPAP and you're hitting that pulmonary edema at two angles and really providing the patient with hopefully an increased and improved outcome. So it's super important to place these patients in the position of comfort, and usually that's going to be head up in a high Fowler's position or sitting upright position, especially your pulmonary edema patients. That's why when they go to sleep at night, they sleep with 4 or 5 pillows because they're trying to keep the edema down in the dependent areas of the lungs. When you lay them flat or you supine, that edema that was only in the bases will now be all the way up, and they'll feel like they're drowning, so to speak. So don't lay your pulmonary edema patients supine unless you're preparing to intubate them. You want to, again, that's going to encourage venous pooling in the legs, which will reduce venous return to the heart, and it decreases the work of breathing. So again, sit them in a sit upright position, and then transport them in a high Fowler's position. Put them on a pulse ox, and you're going to provide supplemental oxygen as needed to maintain O2 sat greater than 94%, as always. And then you're going to use CPAP to manage ventilations with pulmonary edema associated with heart failure. And they receive all kinds of benefits. CPAP helps improve oxygenation and perfusion by reducing the work of breathing, by maintaining alveolar inflation. It improves pulmonary compliance. It slows the respiratory rate, thereby decreasing the work of breathing, the heart rate, and your systolic blood pressure. It will help facilitate delivery of bronchodilators because you can do inline nebulization with CPAP. And it reduces the preload and afterload, improving cardiac output. And overall, it just decreases the work of breathing, which is a huge benefit to CPAP. But you can't use CPAP. You cannot use it when there's a compromised airway. Somebody's got an altered mental state. They have to be compos mentis and conscious. You have to be able to explain it to them. If there's a risk of aspiration, you don't really want to use CPAP. The pneumothorax patient, of course, you wouldn't want to provide that much pressure. Systolic blood pressure of less than 90, you can't use CPAP or high PEEP devices when somebody's got hypotension. It just makes it worse. And it may be necessary to intubate or provide an advanced airway for these patients. So make sure you monitor the respiratory status and use waveform capnography. I can't emphasize that enough. Waveform capnography for all of your patients that are presenting with any respiratory ailment. And then limit the patient's physical activity so they don't have an increased work of breathing or increased cardiac workload. Also, place the patient on a cardiac monitor and obtain a 12 EDKG. All of your CHF patients, you should get 12 EDKGs on. And you're going to see some things that are pretty pathognomic of CHF, like LVH with strain or left bundle branch block, those kinds of things. You want to make sure you establish IV access and provide pharmacologic therapy for heart failure. It may vary slightly by EMS system, so check your local protocol. You may want to give sublingual nitro. Okay, that's a very important therapy for your CHF patient. Some systems still provide Lasix or furosemide. It's not currently recommended for use in treating heart failure and acute pulmonary edema in the pre-hospital setting. However, they will be prescribed it a lot of times. Some agencies might still be providing IV nitro or Tridel drips as well, which is also a good benefit because you could continuously provide nitrates while the patient's on CPAP. So your surgically implanted ventricular assist devices may be used in patients who have heart failure. Obviously, this is something that's going to be done down the line in the hospital by a surgeon, and they act as an artificial ventricle. So we're talking about the patients that have a really decreased cardiac output, okay? And that's kind of their last-ditch effort to save this patient. And it could be used as a bridge device to heart transplantation. It does not depend on the contractility or electrical conduction of the patient's heart. It can be placed in the left ventricle. That's called an Lvad. The right ventricle, which is an RVAD, or both, which is a biventricular assist device, or BiVAD. The Lvad is probably the one you've heard of before. It's generally a term used to describe all three, but there are specific names for each one. Again, since left ventricular failure is more common than your right ventricular failure, the Lvad is going to be the most common type of ventricular assist device. And a ventricular assist device may be used in the following situations. To allow the heart to rest until the patient's heart can resume its pumping function, as a bridge to heart transplantation, as lifetime therapy, also called destination therapy. There are several types of VADs, and they typically consist of a blood pump, tubing, which is an inflow cannula and an outflow cannula, an external power source that connects to a controller, alarms. They are categorized according to the type of blood flow, so continuous or pulsatile, the length of time the device could be used for circulatory support, so they have short, intermediate, or long-term VADs. The source of driving power, so they have pneumatic or electric, and then they have a device location as internal or external VADs. The patient's weak or absent pulse may make obtaining a blood pressure using a manual cuff and stethoscope and obtaining a pulse oximetry reading difficult, if not impossible. It's very difficult on patients with VADs to obtain those vital signs. And again, the types of VADs include your transcutaneous VADs, where both the pump and the power source are located externally. And they'll often have them like where they wear them around their neck and they're hanging around their belly. Implantable VADs, now these the pump is located inside the body, and the power source is located externally, of course, because they have to switch out the power source. Your LVADs, which is where blood is withdrawn from the left atrium or the apex of the left ventricle through the tube into the LVAD, and then it is returned to the ascending aorta via a second tube. That's probably the most common type of ventricular assist device. In RVADs, blood is withdrawn from the right atrium to the right ventricular assist device and is returned to the pulmonary artery, so it bypasses the ventricles, so to speak. Complications associated with these VADs include device malfunction or failure, and that's bad because the patient could die. Thromboembolism, because it's a surgically implanted device. You always have a risk of a thromboembolus with those things. Bleeding, right ventricular failure could be caused. Infection, of course, because, again, it's a surgical device. Sepsis, due to that infection, is also a bad secondary thing. And then a ventricular assist device coordinator can assist you with making the treatment and transport destination decisions. These are often at specified centers. Tampa General, for example, has a VAD coordinator. So you want to contact the VAD coordinator if the patient with a VAD experiences a cardiac arrest. And if the patient requires defibrillation or cardioversion, be careful not to place the pads directly over that pump. And again, it's going to be a very weird cardiac arrest in the sense that it's a non-traditional therapies. And with that, that brings us to the end of this lecture video on heart failure. Please continue on to the next lecture video on cardiovascular emergencies.